Hi, I'm Alice Payne Merritt. I'm a Deputy Director at the Center for Communication Programs at Johns Hopkins University. We do have interpretation. Please click on the globe icon in the Zoom control bar to listen to the webinar in French or Spanish. Click on Mute Original Audio to remove the English audio from the background. You can feel confident that we will share the recording with all participants after the webinar. To ask a question, please use the Q&A function in the toolbar where you see that arrow. We're going to use the chat function to share general announcements and to pose a question to you all, the audience, later in this discussion. And now I think we will get going with the session. We have 4 fantastic speakers today. The format will be, they will briefly share their insights, followed by a few questions to them, and then we want to hear your questions and comments that we will pose to them. I will now introduce our 4 great speakers. We will begin with Ombretta BAGGIO, coordinator of the RCCE Collective Service. Lawrence Sao Babawo, senior lecturer at the School of Community Health Services, Njala University in Sierra Leone, and member of the Scientific, Technical, and Advisory Group for Emergencies on COVID-19 in Sierra Leone. Christine Prue, Associate Director for Behavioral Science, CDC, National Center on Emerging and Zoonotic Infections. And Tamar, Associate Professor, Department of Health Promotion and Community Health, Faculty of Health Sciences, American University of Beirut. Our first speaker today will be Ombretta BAGGIO, and her remarks will focus on a global RCCE response, challenges and opportunities. Take it away, Ombretta.
Thanks, Alice. Thanks, everybody. It's so exciting to be here with you and have a dialogue with all the practitioners and the experts outside there. I want to start with a bit of trends analysis, some data that we've been coming across that can help us in the discussion today. And there is a slide up. I'll be very quickly, you'll have this slide at a later stage, but I just want to bring you through the journey we've gone through. So the collective service is a collaborative partnership between UNICEF, IFRC, WHO, GORN, and is bringing together a number of partners from CDC to NGOs to a number of networks and faith-based organizations. What we've encountered in the past month is really a fragmented data landscape. And the journey we've done is to make sure that we align and streamline the way we collect data and what data powerful data to the decision makers to really take informed decisions. Lately, we've done a trends analysis, and this is coming from data. We've been able to gather data from 188 countries. We have 88 data sources. We'll share with you the data tracker. What we see in the data is, and this is just a portion of the analysis we're doing as we speak, but we see some positive trends. For example, people's perceptions of the risks of getting infected is increasing. And we've seen, for example, data coming out of Asia Pacific, 15 countries with people scoring 50% and more around their perceptions of the risk. Something that is of value to all of us is also to understand vaccine acceptance. And we've seen across 105 countries that there is a high, this is high, though it is decreasing in the first quarter of 2021. And there is a great variation across countries, not region, across countries, with lower level of acceptance in MENA. Another important factor is the social factors. And we've seen data coming out of 185 countries around disorders, around people taking the streets really sometimes in a violent way. We've seen that back in April. We've seen that again at the end of last year. These disorders appear to be much more common in high-income countries such as Europe. So for us, it's very important to be able to streamline the data collection, and we've really worked hard on a behavioral framework with the core indicators. And I'll talk more about data, which is our obsession at the moment, and it was also last year, but I'll talk more about data later. I'll move quickly into some of the lessons we've learned in the past year. And of course, there are many more that I hope you will share, but we've seen COVID global presence and social transmission pathways require really a social and community response. Community engagement lies on a spectrum, and we've known that, and you've been the expert there. I'm sure you've done great things out there. But this spectrum goes from information sharing to co-designing with the communities. The more we are towards that side of the spectrum of participation and co-designing, and the more effective our response will be. Although, especially in phase one of the response, but we still see that now in many countries, there are over-centralized and command and control type of actions. And of course, this is hindering an effective engagement of the people, and is in many cases augmenting issues of mistrust. In some instances, the action has been militarized, and we've seen how this is really putting off communities from adhering to the social measures or leading the actions in their community. And we've seen that in Ebola. So 3 lessons coming out of our the interaction with many countries. The first one is that investing in community engagement systems pays off. So we've seen that in countries such as Malawi, Southern Mozambique, India, Burkina, Malaysia, Nepal. If there is a pre-existing community engagement structures and investments, then is more likely to have stronger and innovative community engagement actions, which are triggered in a faster way. So in Malawi, in Southern Africa, we've seen, for example, community leaders working hand in hand with local administrators to engage migrants returning from South Africa in testing and contact tracing activities. In Burkina, we've seen, in Malaysia, we've seen frontline workers launching massive national campaigns and localized campaigns where they are. And in Nepal, we've seen a great innovative experience of engaging people through Facebook groups. Second lesson, and I'll go quickly to the second lesson we've seen. Community engagement, as I said, lies on a spectrum. The more we move up from information to more treating information sharing to more treating communities as partners, the more effective we are. And that we've seen, for example, happening in Kenya, in Afghanistan, in Liberia, and in Brazil. And my last point is going to be we need a predictable coordination system that helps us in moving faster, more effectively into the response. I'll stop here with the lessons learned, and I hope to say more as we go. Thanks, Alice, over to you.
Thank you, Ombretta. That was great. Just 2 reminders, please put your questions in the Q&A because we want to have an interactive discussion, and we'd like to discuss your questions a little bit later. Also, we will put a link to the bios of each of our panelists in the chat. And now we'll go over to Lawrence Babawo. And Lawrence is going to talk about his experience in community engagement in the COVID-19 response in Sierra Leone. Over to you, Lawrence.
Thank you very much, Alice. I will give a general overview of community engagement, bearing in mind, of course, our past in the last Ebola outbreak, and also try to bring it into the present COVID response. But I want to start by saying that community engagement and other community-centered approaches during public health emergencies have been increasingly recognized as important health emergency preparedness and response activities within Sierra Leone. This importance of community engagement to foster enabling and reinforcing conditions for behavior change to reduce the spread of the disease was exemplified by the 2014-2016 Ebola virus disease outbreak. And then when we do assessment of the Ebola disease outbreak of 2014, we found out that while Ebola awareness and knowledge were already high in Sierra Leone, misconception, stigma, and other barriers, we are very, very prevalent. So community engagement within the health sector, for example, in Sierra Leone, has been seen, especially in the present COVID-19, has been seen to be a critical to achieve primary health care and promote people-centered services. It has also been said that it is a way of supporting some buy-ins and sustainability interventions regarding the present COVID-19 response. It also have improved in the advocacy activities of the COVID-19 response. It has improved the quality and satisfaction of services and contributed to health system responsiveness and strengthening. So these are the first issues that we saw when the Ebola, when the COVID-19 struck in Sierra Leone. We saw that the structures we are now revitalized, those structures that were there within the Ebola outbreak. But then more specifically, we saw the community engagement pillar, social mobilization and risk communication pillars being revitalized. I mean, that speaks, for example, for more reason why we did not see a spike, for example, in the spread of the pandemic in Sierra Leone, because all those lessons that we learned from, for example, in terms of how we are going to, in terms of adhering to risk communication messages, were all put into practice. And I think it was a good thing. And that's the reason why this response, this COVID-19 response has put community engagement as a pivotal kind of activity that has kind of helped the response. I'll stop there.
Great, thank you, Lawrence. Now we'll move to Christine Prue, who her remarks will focus on social and behavioral science aspect of mask use in the United States. Go ahead, Christine.
Thank you, Alice. As many of you know, last April, the White House Coronavirus Task Force and CDC recommended that people wear cloth face coverings in public to slow the spread of COVID-19. This is the first time we've ever recommended that behavior. And we were able to field a survey within days of that recommendation being made, and we're able to track that behavior with monthly surveys from April through November, which, you know, the way governments move, that was pretty miraculous in and of itself. Our instrument actually applied social and behavioral science theory, which we know. This audience knows that social norms and self-efficacy and attitudes towards behavior matter. So we built an instrument that measured it because we didn't have any baseline data on this new behavior. We were able to analyze the data quickly and get it to our leaders to monitor progress and give them situational awareness on how people were, what the uptake was and how people were doing and what the barriers were. And mostly our communication folks were the power users of the data that we were generating, because then they were able to shape messaging to address issues that people were conveying through the survey data. We had a strong analytic team that was able to publish the findings in a couple of peer-reviewed journals very quickly, so we could share what we were learning with others, and that was great. And we were able to combine the data sets over the 8 waves of data last year and connect it to epidemiologic data as well as policy level data in terms of where mask mandates were, because we know that policies are intended to influence behaviors. The local outbreak situation might influence behaviors, and the behavioral constructs, things we know about what influence behaviors could, and we were able to connect all those dots. So those are some things that we did well, but there were some things that we did not do so well. One is really doing qualitative inquiry about why people were and were not doing this new behavior. And that's still something that we need to do more of. We could have done a much better job looking at face mask use in specific populations, as well as in specific contexts, whether it was different workplaces or nursing homes or correctional facilities. We didn't do a good job at looking at this behavior in those contexts. We certainly could have used larger sample sizes. We did small surveys because it's what we could do quickly. And the small surveys didn't allow us to do what this group knows is important, which is segmentation and looking at specific populations. And that was something that we did not do well with. The other two things we could have done a better job with is looking at this specific behavior in the context of the many behaviors we were asking people to do. I mean, how were people doing one behavior, or were they doing all of the behaviors? Were they doing some of the behaviors? How were they making decisions about what behaviors to do when and what contexts? Those exchanges that were people making, we didn't have really good insights on. And then lastly, as the science of face mask use emerged in terms of efficacy, we didn't do a good job integrating the science base for this behavior and the audience insight of the behavior to shape recommendations and guidance that incorporated both data streams in them. That's it. Thank you. Back to you, Alice.
Thanks. Great, Christine. Now we'll move on to our fourth panelist, Tamar Khabakia, and Tamar's remarks will focus on social and behavioral perspectives on people's actions to COVID-19 precautionary measures, examples from Lebanon. Go ahead, Tamar.
Thank you, Alice, and thank you everyone for joining us to this webinar. I want to address the non-uniform, adherence and compliance and the public's experiences with the communication messages and the endorsement of the precautionary measures. And we did an analysis with colleagues at the Faculty of Health Sciences looking at the context in Lebanon and identified three important factors that would actually conspire to affect people's actions or inactions in the face of this pandemic. The first one relates to the collectivist nature of the society in Lebanon. Social ties are dense in Lebanon and they manifest through extended family structures, through kinship. And this is similar to many multicultural settings around the globe. And the social setting has influenced the spread of both harmful as well as beneficial behaviors that would actually related to the prevention strategies during this pandemic. For example, there were communal living arrangements of extended families. And for those people, it was really difficult to understand and implement social distancing measures. Other examples are also related to the communal celebrations of good news and bad news, which is embedded in social norms in the Lebanese context. And actually that makes it difficult to implement those precautionary measures. But also this collectivist society was sometimes beneficial in terms of mobilizing communities. And there were examples from villages where the people mobilized to contain the spread of the virus and to help the management of cases in their communities. The second point relates to social vulnerabilities. And in the context of Lebanon, which is burdened with political instability, with economic collapse, and with the lack of protection schemes, there are large numbers of refugee populations, of migrant workers, and also crowded prisons with incarcerated individuals there who are experiencing multiple vulnerabilities. So for these resource-poor groups, staying at home is not an option where they need to earn their daily wages. For migrant workers who were abandoned by their employers on the streets because of the economic collapse, there was no protection from the raging pandemic around them. And also for the prisoners who were sharing crowded cells with a large number of individuals, there was no way to implement precautionary measures that were recommended. The third contextual factor we addressed in the context of Lebanon is the political system, where we have an unequal sectarian system that gives a large space during this pandemic to political parties. And it reinforced clientelism and contributes to the heightening public feeling of distrust in the system and in the state. And consequently, this also builds a feeling of distrust in the messages that is coming from the authorities, specifically when it relates to lockdown measures that are put in place. So in our analysis, we wanted to show that a realist approach to communicating during this emergency minimized the effectiveness of risk communication. And we showed that the complexities that are involved in the implementation of the behavior for specific groups of the population need to be considered in future approaches. Thank you, and back to you, Alice.
Great, thank you, Tamar. Now, as we collect your questions, we're going to go ahead with a few questions to the panelists. This is a question for all panelists. Based on your experiences that you just shared, what are 2 concrete recommendations from your lessons learned that we can apply to future challenges? We'll go ahead with Ombretta first.
Thanks, Alice, and thanks, everybody. These presentations were great. Some recommendations. I'll go back to my early point around data. What we see happening in the pandemic since last year is that there is a misinformation issue, but above all, we have an issue of trust. And to build trust, we need to listen and we need to act. It's very important that we understand the level of trust and we understand what's behind issues of mistrust. So it's very important to streamline and strengthen the collection, analysis, and use of social and behavioral data. And that's the journey we've done through the collective surveys, but also pay attention to the real-time community insights, which are complementary to some of the survey data that you've all been collecting. So really making sure that we use and act on some of those community feedback, community insights that are coming our way, and we bring them together to be shared with the decision makers. That's very important. It's important that we have an accountability system as well, which means acting on the data means that once we have the data, we need to act on those. So we need to start measuring success through people's feedback. And this accountability system means that in our data, we need to really measure community participation and satisfaction level. I think Lawrence, you've talked about satisfaction level in Sierra Leone. So we need to be accountable and be measured in our action by what people say. We've seen in the data last year how people feel disempowered and not able to influence decisions. It's very important to track that. And my last point is around again, being consistent in our investment into community engagement. We've seen how successful countries have invested earlier in community engagement structures and systems. And this we've learned over and over from the West Africa Ebola outbreak through DRC. Through this outbreak, we need investment before an epidemic strikes. Over, Alice, to you.
Great, thank you, Ombretta. Lawrence, same question. What are, based on your experience, what are 2 concrete recommendations from your lessons learned for the future?
Yeah, thank you very much, Alice. I want to answer that question by looking at the issues in community engagement that have worked out well during this COVID response. Because by so doing, that will in itself serve as recommendation. I mean, one of the things that we have recognized, that we have seen during this COVID-19 is that there has been the recognition of community ownership of the response itself. And when this community ownership of this response itself, the COVID-19 response, there is now a 2-way communication, and there is active participation of the community people. And therefore, you see adherence to the COVID-19 restriction messages, for example, that are sent around. So that is one thing that is working, that has worked, and that is also working. The second thing is that the response structure, the response architecture has recognized, has incorporated community engagement interventions as a critical pillar for this epidemic response. So the community engagement interventions that used to happen involving people, listening to people, carrying out risk communication messages all over the place is holding water, and it's producing very, very positive results. So that could be another recommendation, that we have to incorporate community engagement interventions within the system, like we did when we got our first case in Sierra Leone. We have also established, what also is working well, there has been the establishment of a supportive infrastructure. Infrastructure, for example, that is helping to work out training, for those who are engaged in the response, and for also giving remuneration at the time that they are supposed to be giving, and adequate to, commensurate to the type of work that people are doing. And of course, that is followed by supportive supervision. And the last thing I want to talk about as a recommendation is that which has worked here, is that we have tried to ensure a very strong field coordination and integrated multidimensional communication strategies. So that is what, so our strategies, for example, in communication, risk communication, social mobilization, is not only from a one-way street. It's a multidimensional kind of thing. We can get the media, social media, the newsprint, the newspapers, the televisions, etc., etc. And there are even people, surveillance officers, who go, or risk communicators who go to the communities down in the most remotest places to talk to people. So these things are working out, and people are cooperating with it. Thank you.
Thank you, Lawrence. Christine, same question to you.
Sure. Two things that I think I would recommend. First of all, for all of us, that we need to be credible and trustworthy in representing the perspectives of the community members we serve. And we talk about trust on many levels, but we have to be trustworthy with the perspectives and representing those perspectives to the leaders and to our organizations, which means just quality, transparency, all the things that we talk about with communities and others. We have to exhibit those behaviors and perform those behaviors ourselves. The second thing is John Maxwell has a quote that I live by practically. It's, people don't care how much you know until they know how much you care. And in this response, we've said, let science lead the way, let science lead the way. I would like to reframe that as, let scientists who are people convey compassion and concern and open posture, because science alone is not going to fix this. I love science. I'm in a science-based organization. I love science, but not everybody's in that same place, and we have to connect with people and let them know we care about them and know our motivations much more transparently. We can't assume that people think that what we're doing is a good thing. We have to really be explicit in communicating our motivations and being transparent in what we're doing and why we're doing it, and engaging people and listening them with us. So leading with compassion and concern, and then following that up with scientific insights and information is what I think we need to rob off. Thanks.
Thanks, Christine. Excellent. Tamar, over to you, same question.
So I have 2 points here to make. The first one actually relates to understanding the context. Now that probably is something really basic that we all implement and understand and, even advocate for. However, what I'm saying, it goes beyond the situation analysis and the understanding of the context. We need to uncover the inherent nature of social networks, understand really the in-depth social values, and then actually reflect those social norms in the messages that we have, in the approaches, in the strategies that we design. And this has been, one of the key learnings out of the context that we analyzed. The second point relates to addressing social inequities as part of the response itself. So we need to mitigate the economic and the social vulnerabilities, and it needs to be part of the messages, and it shouldn't be vertically working, you know, in parallels. And that would build trust. That would actually reinforce the empathy approach that we were just talking about and Christine mentioned. It's understanding those social values and social networks and social experiences that would bring out the empathy in our approaches, and it will build the trust that we need. So we need to really address these social vulnerabilities and embed them in our response. These are the 2 points that I want to make for now.
Great. Thank you, Tamar. Now we're going to move on to another question, and this is really critical for all of us listening today. How do we ensure that SBCC, RCCE is a core component of the public health systems included in an emergency response, such as incident management systems? Christine, we'll go to you first for this question.
Have lots of thoughts on this, having worked hundreds of outbreaks in my career. And I think if I were to say one thing that needs to happen is we have to revisit the incident management structures, because form follows function. And most of our IMS structures have a communication component, which is great, the joint information, JIC, whatever you want to call it. But there isn't a focal point for social and behavioral sciences in response. There's an assumption that it's integrated into the various pillars or response activities. And I'm telling you, it's not. If it's invisible, it's not intentional. And I think we need to look at our incident management structures, because they're supposed to be structures that are built, that are time limited, that have clear functions and connections between them. So it's supposed to be interoperable. Somebody just plops in and knows what they're supposed to do. And until we have a social and behavioral science box or focal point or unit that is dedicated to listening and learning and applying those lessons across the entire response, it's not going to magically happen. And I think we have got to change our structures to prioritize, to actually get a seat at the table and to broker and connect. I mean, I love that social behavioral science is baked into communication, because communication at its core is a social science. But that's just one part of the incident management structure. We've seen in COVID that there are social aspects to contact tracing. There's social aspect. We know there's social dynamics around healthcare seeking behaviors. There's social aspects of being able to quarantine, not quarantine, travel. And the fact that, we expect each of those pillars or groups or entities to sort of figure out the social behavioral norms or the dynamics around those behaviors. Most of the epidemiologists or other even folks who are in those domains may or may not have social behavioral science background to tackle those issues. So until we're intentional and having focal points for social and behavioral sciences in emergency responses, I think we're going to still see the messiness that we have. I know for the Ebola response in DRC, the CDC's, for the first time ever, had a social and behavioral science task force built into an incident management structure for that response. And it made a huge world of difference in that response. For the COVID response, there wasn't a focal point. And I think we saw the messiness of that.
Thanks, Christine. Very important. Lawrence, same question to you. How do we ensure that SBCC, RCCE, is a core component of the entire public health system emergency response? Lawrence.
Well, the role of SBCC or RCCE, whether at the beginning of an emergency or during emergency, is basically to engage the public, to support them in making informed decisions. The communication-related pillars, for example, has to be reawakened, like we did in Sierra Leone, and that is done through a couple of activities that we have done here, which has also played out. For example, we had to, at the beginning of the pandemic, we had to develop a robust coordination structure, put a reawakening of a robust communication structure, which with every specifications as to what they were expected to do, you know, because our experience was in the last Ebola was that, I mean, there were communication structures that whose roles were not completely defined. And therefore, at the end of the day, there were a lot of confusions, but that has not happened. So this time around, people have been, or organizations have been given coordination roles, you know, and with clear mandate as to what they are to do. And then also, there has been a lot of community engagement and mobilization activities, like I was saying. I mean, that was absent, for example, in the past Ebola outbreak. But now the communication and social mobilization activities were stepped up. And you go, for example, to villages where you already have what we call the community healthcare workers, which is employed by the government. You have the village development organizations. So all these groups within the community at the community level have been involved in social mobilization. They are actually part of those groups that have been formed within the village level, within the chiefdom level, within the district level. So you will see that a lot of issues are playing out. Social mobilization messages and risk communication messages are actually playing out, and they are getting the relevant attention that they have been, or they are getting the relevant result that we expect to do. And then we also have seen that there has been, during this COVID-19 response, there has been identification of mitigation measures, both at the individual level, both at community level, and both even at national level. So mitigation measures at individual level, that which has to mitigate, for example, your chances of getting the COVID, has been very clear. As an individual, what you need to do, as a community, what you need to do, and as a nation, as a country, what needs to be done in order to reduce those things. And of course, we have been having a promotion of social and behavior change approaches also, like I said. I mean, a lot of those things that we experienced during the Ebola, which we now learn from, are helping us, you know, for people to understand that if we don't adhere to those measures, we will land ourselves in the same problem like we did during the Ebola outbreak. So those are some of the issues that I will talk about, or that we have, the lessons we have learned from the Ebola outbreak that is now helping out, or which can help out the SBCC and RCCE activities. Thank you.
Thank you, Lawrence. Ombretta, same question.
Thanks, Alice. Lawrence, it's great to hear you talk about coordination, because I think what Ebola has been teaching us is that we really need a predictable, consistent, and localized coordination system. And you in Sierra Leone activated so fast, much faster than other countries where we didn't have that. What we say, what we've seen happening across countries is that unless we have community participation front and center of frameworks, strategies, and policies, these investments are not going to happen. And we need to have those really happening before an epidemic strikes. We've seen that the architecture, as Christine was saying, the coordination architecture of the response is a barrier to nimble working. So if we want an agile community engagement process and an agile response, which we need really to invest into an agile system and a different system, and to make sure that behavioral data, social and behavioral data are systematically looked at, they are collected, and they are used. And this is what I said before. We need an accountability system so that community voices, community insights, social behavioral data really drives our action, and we're held accountable for changing and course correcting our action. So I think COVID is giving us the opportunity to make those systemic changes, and we need to jump on that opportunity and make the case for these changes. Over to you, Alice.
Great, thank you, Ombretta. We're going to move on to the next question, which is how can we strengthen SBCC actions when government systems are weak or there is little trust in government systems? Tamar, I'll pose that question to you first.
Thank you, Alice. So I think in situations where we have weak states, this pandemic came to expose a lot, and especially the lack of infrastructure. And that infrastructure was needed for a timely response, for an adequate response. So maybe investing in building such infrastructures is what we need to pull resources for in the future. So building not only human capacity, but also systems in which you can have data ready for you to act upon whenever an emergency is there. Also to build the processes for stakeholder collaboration, systems for community engagement, put that in place. So this brings us to preparedness plans. And when you have weak states, you also need to coordinate with other more powerful or more engaged stakeholders to fill in the gap where this and prioritize these kinds of preparedness plans within the other priorities that are competing, you know, within that structure. So also, I think we need to look at we need to give the ownership of the solutions to communities, because when the state is weak, you can actually build structures within communities that can be really useful in times of emergencies. So a lot of work, I think, for the future. There are a lot of lessons learned from this pandemic to embed more in our community engagement approaches and to build infrastructure in the various dimensions of that infrastructure to actually have more horizontal responses rather than vertical top-down from the state.
Thank you, Tamar.
Back to you.
Lawrence, same question to you. How can we strengthen SBCC actions when government systems are weak or there is little trust in the government?
Thank you very much. I want to look at that question from different levels. If you look at it, how you strengthen it in a weak system, for example, like we have in Sierra Leone, like a weak government, then during the Ebola, for example, you should have to look at those questions from both the national level and the community level. If you look at the national level, you need, like Tamar said, you need to look at the infrastructure. You know, one of the key things that came out during the Ebola outbreak in Sierra Leone was its very, very, very weak infrastructure. I mean, when I talk about infrastructure, I'm talking also about the physical structures that were there, the physical health structures that needed to be in place, which were not there, and also the personnel that has to be there to accommodate, to respond to the outbreak as one would expect. That was visibly lacking in Sierra Leone. For example, during the Ebola outbreak, we had only one epidemiologist employed by the Ministry of Health and Sanitation. That tells you why, or that shows the reason why we were overwhelmed the way we did. So infrastructure is an important aspect. Otherwise, you will soon, the outbreak is going to overwhelm you in no time. So infrastructure is an important thing, taking into consideration the physical buildings, the facilities that are supposed to be there, and of course the personnel, like I was talking about. And then you also want to, at national level, you want to look at, what are the documents that are there, which was absent in Sierra Leone? We did not have any supportive policies and legislation, for example, regarding epidemic outbreaks. There were none. So at national level, we need to advocate for supportive and policies and legislation that people are going to, fall back on in an event of this kind of the magnitude of the kind of disease like the Ebola we had. And then, of course, at national level, we have to communicate the policies and protocols. You have to let people understand that these policies do exist and they are communicated at that level, and that can be cascaded. If you look at our health system, the way our health system is structured, it is from the national, you go to the region, then you go to the district. So those policies can be communicated using those structures. I think at national level we can do that. Of course, the other thing that we need to do at national level also perhaps is to organize outreaches and develop communication outreaches. And we also have to, at national level, address beliefs and misinformation. That was another serious issue that came in. That is at national. If you come to community, at the community level, for example, you need to address social and gender norms and practices. Those things we are very, very, very much missing. For example, during the Ebola time, female relatives, for example, we are not allowed to kind of do the last offices to their female counterparts who had died as a result of the Ebola. So those things have to be taken into consideration at community level. We will also have to cultivate and identify and place community champions. That is important. That is where the community ownership comes in the whole business of community engagement. And in a situation where you don't have the community owning up, I mean, trying to understand that this particular thing belongs to them or they are a part of it, they are soon going to be apathetic, and then nothing will happen, and then the result will be devastating and the impact will be nil. So we have to do that. We also have to, at community level, the right information, the correct information. Those infodemics, you know, there were a lot of infodemics during the Ebola outbreak, and that also started during the COVID-19 pandemic. So we need to handle those issues, you know. And of course, we address the biases that are there. We have to address the beliefs and misinformation and the conspiracy theories that do exist, because those conspiracy theories are very, very much rife within the community level. So we need to do those things. So those are the issues I think we have to do both at national and community level. But there are also things that you can do even during, that is before the outbreak, during the outbreak. When the outbreak is actually, now what do you do at national level? You have to develop job aids. You have to develop people and employ people to help the ones that are leading in the response. We also have to revitalize and strengthen existing response structures. Of course, then you have to plan and implement and do campaigns. So these are some of the things that I would suggest that we have been, that has come out to be very positive issues that we can adopt in a system that is weak, in a system where trust is also lacking in the government. I hand you over to Alice.
Thank you, Lawrence. Important points. Now a question for Christine. In your experience, Christine, what kind of, or which kind of SBCC, RCCE capacities should we focus on strengthening for future emergency responses?
Great question. I think there are 3 buckets in my mind that we need to get better at, and I'm always trying to get better at as well. And first bucket is in the thinking bucket. We really just need to get better at receiving data, interpreting data, making meaning of it, because we got lots of different data streams coming at us now, and volume doesn't mean quality, it just means volume. So we need capacities where we are good thinkers and we are able to process information and represent data in clear and concise ways. And that's really important because I don't know about your leaders, but my leaders they're processing a lot of information. They can't handle me throwing a lot more information at them. I have to do the heavy lifting of reflecting and analyzing and digesting as robustly and as speedily as I can, so that information can be used. The second bucket is, so that's the thinking bucket. The other is the doing bucket. We have to have strong methods, and we have to be good methodologists in terms of not only how do we take those insights and turn them into action, but how do we engage the community with the same data and engage them in that, the decision making and the influence and the problem solving. And there are lots of right ways and wrong ways to engage communities. So that action piece, that translation piece, that important, how do you turn insights into action? We need to get better at that. And we need to do that. We need to learn how to do that faster, more transparently, and in ways that really acknowledge important issues like power and control and consequences. We have to sometimes be okay in giving up control, but we also have to convey what the consequences are to the choices that communities make. So, and that's got to be okay with us because we're all working in very different contexts. And then the third bucket, I would say, is evaluation. Is we talk evaluation a lot, but we don't do a really good job of really baking it in from the beginning and saying, okay, here's the cascade of effects we anticipate. Here's the messiness of the environment, and what are good indicators that tell us whether we are heading in the right direction, whether we're headed in the wrong direction, whether people are being harmed or not harmed by the interventions that we're proposing. So I think the three buckets, I would say, we need to get better at sort of the thinking analytic end, the application and the doing end, and sort of translation step, and then the evaluation, the signals on how do we know what we're doing is the right thing to do and is taking us in the right direction.
Thank you, Christine. Yeah, really, really important points. Now we've collected many, many interesting questions from the audience, and we're going to sort of try to go through a lightning round to get to as many questions as we can. The first question I have from our audience today is, how can we involve people from communities more as partners and involve them in the co-design aspects of what we're trying to do? And as part of that, how do you gain the community's confidence? Tamar, maybe you can go ahead and take a whack at this one.
I'm going to start with talking about empathy. I think the communities we need to gain the trust of communities, and it shouldn't start as a reaction of an emergency. I was talking about, the pre-emergency, the pre-crisis phase as being really important. So building those structures that would enhance the trust and building in empathy in our approaches, in our strategies, are going to be key in that sense. So with a lot of fatigue that is coming now with the pandemic, vaccine hesitancy and all of that, this has become even more and more important, more efforts and more resources need to be put on finding what would work in terms of community engagement, in which context. And going back to the point that Christine was making about evaluation, I think it is important to document those experiences and to monitor and evaluate, because we really need the evidence, and we really need to know what are successful experiences that could be scaled up. So, we don't know much about this, and the pandemic is teaching us a lot of good lessons that we need to highlight and evaluate and document and advocate for scaling up.
Thank you, Tamar. Thank you, Tamar. We are going to post also a question for everyone on this webinar, the audience, about the impact of COVID-19. As we know, it goes beyond public health. We're focused on public health and behavior change and risk communication, but COVID has really touched every aspect of life, from school closures to unemployment, to violence against women and children and mental health issues. We'd like to hear from you all, the audience. What lessons have you learned, and what are the implications for SBCC policymakers and practitioners? So we'll post that in the chat, and please, we share your insights. As we hear from you all, we're going to continue with our questions. A next related question is, how did the pandemic change community engagement approaches? What lessons do you have to share thus far about how we can do different kinds of community engagement, especially when meetings and other face-to-face encounters have been prohibited? Lawrence, would you like to respond to this one? Lawrence, are you there? Can you all hear me?
Yes. I think I'm. Okay. Sorry. I was on mute. Like I was saying, community engagement in Sierra Leone, for example, during the COVID-19 has played out to a great deal. And because it had played out to a great deal, it is as a result of a few issues that has to be taken into consideration. For example, we want to be able to look at how much trust that people have had, the community have had in the country or in the whole system that we are, in the whole system that is leading the response. That's one. You know, and there has been a consistent engagement with the community. It is not the type of engagement that we saw when various organizations will come in with different methods, with different engagement at different points in time. And therefore, at the end of the day, there was a lot of confusion that we experienced. You know, we even look, for example, at the case definition of Ebola during those days. You know, you will realize that all organizations that came had their own definition. And that created a lot of confusion, and that's also created mistrust. So those things, so whatever messages that should come, whatever things that you are going to tell people, you have to ensure that it is consistent, and you try to let people understand that they actually understand what you want them to understand, what you want them to know. I mean, rather than giving them information that are vague, that are not clear, and that kind of thing. Another thing that has also played out probably very well in this COVID-19 is that aspect of supportive supervision, supportive monitoring and evaluation, somebody was saying. I mean, there is a laid down pattern, for example, in the collection of data, for example, regarding COVID-19. I mean, we did not have that during the Ebola outbreak, but there's a laid down pattern that people have to follow. If you want information, data about COVID-19, there's a pattern, there are structures that you have to pass through. And those structures are the only structures that are responsible, for example, of giving out information. So these are some of the issues, I think, that we help out a lot in the future, for example. Back to you, Alice.
Thanks, Lawrence. Thank you. Now we have a question a little bit of a different nature. I thought, Ombretta, you might respond to this. How did faith help or hinder best behavior through the pandemic? Are there any studies? Is there any data on this?
That's a great question. And by the way, we happen to have had yesterday a presentation from different examples of successful work with faith-based organizations. And I think I've been really I've been impressed by this work. So what has happened is that we've had experiences from India, from Kenya, and I know of a great experience in Afghanistan, but faith-based organizations have been taking the lead in recommending public health and social measures, but also in adapting practices in their religious in their day-to-day religious practices. And I think the learning coming out of that is how important it is to have trusted sources such as the religious leaders to be the ones passing the message, to be the ones adapting and localizing the practices and addressing some of the myths and rumors coming out. In India, they're rolling out a massive vaccination campaign, is one of the first countries doing that. And the power and engagement of the faith leaders has been impressive. And I don't have data. And in fact, yesterday we were discussing about this data. UNICEF is leading in this type of work together with WHO. And what has come out is really that there will be more investment into monitoring how this is impacting on behavior change. But I've seen over and over from Afghanistan to India to Kenya how religious leaders makes the difference when they are engaged and at the forefront of shaping the action and changing and adapting their practices in their work. Over to you, Alice.
Thank you, Ombretta. Here's another question, perhaps Christine. Oh, Christine, would you like to also answer? Please go ahead.
Yeah, I think it's just really important to mention, as important as it is to engage faith communities, to promote mitigation behaviors. That's great that they're allies in that things. I think the main business of most faith-based communities is to bring hope and through you know, the spiritual dimensions of people's lives. And I think that's as primary as a purpose as ever when people are facing the major disruptions to our lives. I know that there were some surveys here in the United States that showed that people who had a faith, any kind of faith relationship, were doing better in terms of their mental health and their well-being in navigating these difficult times. So let's let the faith folks do what they primarily do and come up and help us with our job, but let's make sure that they're doing their main job, which is bringing people hope.
Great point, Christine. Thank you. Maybe Tamar, you could respond to this question. How can we mobilize social media platforms more effectively? Many of them have been very helpful, but how can we leverage them more?
I think, again, I'm going to talk about investment in the long term, and I'm going to talk about e-health literacy. And I think we should use the social media platforms to build health literacy in the groups that we are targeting through our social media. We need to also give tools to influencers and people who are savvy on social media to join forces with them. So it's another, you know, important group of stakeholders that we need to invest in our long-term strategies in responding to emergencies in the future. I cannot stress enough the importance of working on building health literacy. I think that is key in the face of infodemic that we were fighting together with the pandemic, and now with the vaccine situation, that becomes really important. Science literacy, digital literacy in terms of social media, but also, you know, all of them pouring into building and empowering more towards higher levels of health literacy in the population. This takes time, and it probably takes a lot of different strategies and a lot of different processes, working with different groups of people on social media to achieve those goals. That's why I think of it as a more of a long-term plan. And there are a lot of experiences during this pandemic, both negative and positive on social media, that we can actually engage with and try to bring out lessons learned for future such activities. Thank you. Back to you, Alice.
Thanks, Tamar. And here's a question. Oh, go ahead. Go ahead, Ombretta.
Do you mind if I say something on the social media part?
No, please.
One of the things that we've noticed is also that, I mean, shaping a bit the question differently is how do we ensure that we mobilize the social media champions more than the platforms, which means mobilize those that have the most followers. So we've seen over and over how youth are really taking action on social media. There is a great study that is coming out of WHO, I think, any day now, from WHO together with the University of Melbourne, really highlighting how young people have a massive amount of followers, from 500 to 5,000. So they're more powerful than any organization sometimes if they are together, and they want to be. So how do we ensure that those champions, they are the forefront of their response and share the information in the language they want and in the shape they want? So going back to Christine, letting go a bit of our power of communicating from a central level and nurturing and really engaging those powerful voices in a different way, I think is critical.
Thanks, Ombretta. And we have an audience question also about social media, but sort of from the other side of social media, that a lot of misinformation can come through social media. And many countries, including the US, there were a lot of conspiracy theories and blaming different kind of officials. How can we address this when there's a lot of false information, conspiracy theories, gaining a lot of momentum on social media? Lawrence, did you experience that in Sierra Leone?
Oh yes, we did experience that a lot. The conspiracy theories were there a lot. And then what we did now during this during this COVID-19 response was actually stepping up social mobilization activities, like I said. I mean, you know, the health system in Sierra Leone is structured in such a way that you have the national, you have the regional, then you have the district, and then you go to the chiefdoms and the villages. So what we did, what was done during the COVID-19, had been done during the COVID-19, is actually trying to involve people in those messaging, for example, right from the community level, right from there up to the top. So much so that you know exactly the message that is being transmitted from the national level would be the same message that is transmitted at community level. So that is one of the ways that we have tried to leverage, if you like, the conspiracy theories and the lies about, for example, vaccines. Now Sierra Leone is rolling out the vaccination for COVID vaccination, and there are a lot of conspiracy theories about that. So those structures that I've just named are very busy now, you know, trying to educate the people as to the reason why the vaccine should be taken, for example. So we don't have as much belief. We don't have as much belief in conspiracy theories in this COVID response than we used to have during the Ebola. I mean, there is a very, very significant improvement in that regard. I mean, I was in my home village yesterday. I mean, a village about 5,000 people, and I saw the number of people going out for vaccines. I mean, on their own volition, because of the messages that have been sent. So that is really very impressive. And I think that once the messaging has been done properly and it has seeped down into the remotest community, consistently though, like I was saying, you don't have to relent, then I think people will believe that what people are saying is correct, and therefore they will adhere to it. Back to you, Alice.
Wow, Lawrence, that is so encouraging to hear. I don't know, Christine, if you have any comment in this area?
Sure. I think there's, if we expect there not to be conspiracy theories and misinformation out there, we're being naive. There is always going to be alternative opinions or alternative facts or alternative, whatever you want to call them. I do think we have to stay true to what we know, tell people what we don't know, and be consistent with that. And there is sort of, you know, a balance of trying to debunk or speak truth to the things that or poke holes in things. But I mean, the balance of, you know, writing wrong information sometimes can lend credibility to the sources of those information because you're giving them attention. So I think you just have to have a strategy for how, or each organization has a strategy for how it's going to deal with misinformation, what kind of attention it will give to correcting misinformation, and know that there's always going to be a lot of messiness out there. I mean, most of our societies allow people to have thoughts and ideas, and we don't have censorship here for the most part. So I do think it's a difficult one, but I do think Tamar's point about health literacy and needing to build that over time is a really big one. I mean, having people have basic media literacy skills where they consider source, they consider, you know, the trustworthiness of the source. They actually, you know, look at the ideas that are being presented and say, do they align with known facts and do the fact finding. I mean, people do have to invest time and energy in order to get correct information.
Yeah, great. Good points, Christine. Thanks. We have just a few minutes left before we close at 9:15, and we have one last question to the panelists. This is a super fast lightning round. As we close, for a question for each panelist, what is one important concrete tip you would like to highlight for SBCC, RCCE in emergency response for the future, based on this very rich conversation? Go ahead, Ombretta.
Thanks, Alice. My one tip is that we need to a two-way trust system, which means we are obsessed with communities trusting us, trusting our information, trusting our recommendations, but we need to be obsessed with us trusting them in the way they give us feedback, in the way they give us recommendations. So it's a two-way street that we're building. And this means that we need systems, ones that are able to have this community feedback flow coming to us. And we need systems where we measure how we're acting on that feedback. And those systems are really important as we move along this pandemic and for the next epidemic.
Thank you.
Over.
Thank you, Ombretta. Lawrence, one quick concrete tip. Lawrence, you're muted.
Yeah. My suggestion is not that far from what Ombretta has already done. I would say we need to have, I mean, based on our experience in Sierra Leone, we need to have a continuous, consistent, two-way messaging at every given point in time. You don't have to keep comes out new to that information immediately in the correct way and in a more consistent manner.
Excellent. Thank you, Lawrence. Christine. One.
Relationships with people who think differently than you do. Get out of your comfort zone and become an expert learner of other people.
Great, thank you. Tamar, one concrete tip.
My tip would be on establishing long-term relationships with communities and being proactive rather than responsive to emergencies. Start from the assets in the community and start from their understanding of the science and build your messages around that instead of starting around the key messages. Thank you. Back to you.
Excellent. Thank you, Tamar. In the last half minute, I want to thank the panelists. I want to thank all of you for joining. I think it was a very rich discussion. We have many more questions we can answer in upcoming, and we look forward to upcoming discussions and webinars. And I really look forward to seeing all of you in Marrakesh in December 2022. So thank you so much for joining and take care. Bye-bye.
Thanks, everybody.